to educate the choices that we make on antibiotics, as well as it comes to duration of antibiotics. In the first world, they can give antibiotics 1 to 2 doses post-operatively if the patient didn't have a perforated appendix. But what I've seen with most of the third world studies that we tend to give antibiotics a bit longer, and we are a bit more generous in terms of the duration and the combination of the antibiotics. So then when it comes to management, where you have to decide whether it's going to be your operative or non-operative. So the non-perforated appendicitis, your early appendicitis, they can be treated with antibiotics alone. And if these non-perforated appendix, they are treated operatively, as I've mentioned, then some centers will give 2 doses post-op or just 1 dose post-op for your non-perforated acute appendicitis. We also tend to do the same. We give them 1 or 2 doses post-op for your non-perforated, just inflamed appendix. And some of them we might choose to send them home on oral antibiotics or not at all not on any antibiotics. When it comes to your perforated appendix, these are the ones that are treated by intravenous antibiotics. And there are some studies that have treated perforated and appendicitis with just antibiotics. But then in that case, that's when you decide whether you're going to do your interval appendicectomy or not. And in the studies that have been shown is that the need for interval appendicitis appendicectomy isn't so much in children, but I'm going to get to that on the next few slides. So as I mentioned, to start off with intravenous antibiotics and move on to your oral antibiotics on discharge as the patient is tolerated. The interesting one of the studies that was done is actually a South African study, which showed that the group of patients that were treated with just antibiotics, about 13% of them recurred, and recurred within the first few 10 days, and 2/3 of those patients that were treated with just antibiotics, 2/3 of them came back post discharge within the first 18 months with needing an operation for appendicitis again. Okay. When it comes to operative management, it's when you have to decide whether you're going to do your appendix laparoscopically or open. So the studies have shown that there's more benefit with doing laparoscopic appendicectomies. The patient, they spend less time in hospital. There's less need for extensive pain management. They start feeding early and they get discharged early as compared to their open appendicectomy. Earlier on, when the laparoscopic surgery started, there was an issue that, well, it might take long theater time than an open appendicectomy, which actually now, in most recent studies, it has shown that it actually takes more or less the same time. And in some studies, it did show that laparoscopic can be a bit longer than open, but the difference was laparoscopic surgery would last about 44 minutes on average, and the open appendicectomy about 36 minutes, which just gives you an 8-minute difference on operative time. But with all the benefits that you get from the laparoscopic appendicectomy, now the world tend to favor more laparoscopic surgery than open surgery. But with the laparoscopic surgery as well, it comes with you need adequate skills. You also need adequate instrument, which are not readily available in some of the sub-Saharan countries. We are lucky to have access to this laparoscopic equipment, and we do have adequate skills to perform appendix laparoscopically. The other question with laparoscopic versus open appendicectomy, it was more about the severity, where your more perforated appendices, your more complicated appendices, which people still even now tend to do open appendicectomy for those complicated cases. But in some of the studies, it has shown some of the authors have been able to do perforated, very complicated appendix, and were able to do it on one operation without needing a relook laparotomy. And they were able to do a good operation without needing to go back further, just laparoscopically, which means that we might be moving to a completely laparoscopic era of treating these appendicectomies. And then when it comes to the interval appendicectomy, it is not recommended nowadays in children. And with that being said, they said that the risk of having the recurrent appendix is the same as the general population. But what we have been doing in what I'm saying mostly in your developing world is that they tend to be more aggressive. They would go in even in a patient that they might be suspicious that he's got a complex appendiceal mass, and they tend to be more aggressive, go on and do an open operation, because we have problems having this patient to come back. Lots of our patients get lost to follow up. Some of the patients, they come back as far as 300 kilometers away. So discharging this patient with with information that if they have complications, they have to come back to hospital. Some of them, they might not be able to get to hospital on time. And following up these patients who are coming so far, it's not logistically feasible sometimes. So that's where we end up having to be a bit more aggressive with our antibiotics, with our operative management of this patient, even though the evidence shows otherwise, that it's better to operate once the inflammation has come down on these patients. So here I'm just highlighting some of the causes of the non-operative management of these appendices, which is some of these causes they identify is the over 15% of your band count on your blood is a risk factor. Fecal if is present, also it is a risk factor. or if there's already a spillage or contamination, not only in the right iliac fossa, or if the patient has already have bowel obstruction from the inflammatory mass that they have. And also in the children that they come in, like I mentioned, already in a septic shock, and those children, they tend to not do well with just conservative management. So some of the complications that we face, the most common is the wound sepsis. And then you get your intra-abdominal abscess collection, your post-op intestinal obstruction from adhesions, and then you develop some, we do see, but not common, your enterocutaneous fistula. There was also a question of whether does it, if you have a perforated appendix with a generalized peritonitis that goes into the pelvis as well, does it affect the fertility of women? And the current evidence shows that it doesn't affect fertility in those women, even though the ovaries and the fallopian tube could be being patient in pus, but it hasn't been shown to affect fertility. So, in summary, it's acute appendicitis is a very common pediatric surgery emergencies that can be fatal with late presentation, and you need a high index of suspicion as well, so that you act immediately if you think it's a complicated appendix. The diagnosis still can be made just on clinical basis. The perforation rate tends to be higher in the community of lower socioeconomic status. As we have mentioned, that this might be affected by the fact that they're coming far, so they get help. It takes them longer to get help than people of higher socioeconomic status, as well as, and especially in our communities of different cultures, there is the different health-seeking behaviors. So some of our patients, medical doctor, a clinic, or a hospital, it's not their first encounter when they have any problem. So they might seek help from their traditional healers before they come to us. And that's why they come with complications. So when appendices are perforated, those are the ones that come with significant morbidity and mortality. Antibiotics, as I've mentioned, just need to use your local protocol, but they still must be cost effective. And you need to be wary of the resistance of antibiotics. So you need to do just a careful prescription of antibiotics. Laparoscopic surgery is still better than open surgery. And as I mentioned, the management of these patients needs to be actually personalized to each patient, because what affects the outcome is not just what's happening in front of you, it's everything that's happening around the patient. It might be the nutritional status. As I mentioned, like our patient also have HIV and TB, and all those things need to be put together before you make a definitive plan for this patient. That's going to be the end. Thank you. That's my references.
Zandile, thank you very much. That was quite a nice presentation about the current knowledge, and you also highlighted our practice of what we do here. So thank you for that. I will now invite Professor Sharif Emil to give his advice and to give his presentation. So Sharif.
Okay, thank you very much.
Thank you. Yes.
Can you see my presentation?
Yeah, we can see it now.
Okay, very good. 1 second. One second, I'm just trying to get it to a different, okay, very good. Let me just go on the presentation view. Sorry.
Has the previous presenter stopped sharing? There you go.
Okay, I just want to try to go on the presentation view. There we go. Okay. Well, thank you so much. That was a very comprehensive presentation, and two thoughts come to mind. First, each of these slides can make for an entire day of discussions because almost all the points are still, there's a lot of controversy. But I think, and this is really what I was looking forward today, to learn a lot from you all. It reminds me of something I often say when I speak about appendicitis in different settings. You hear all politics are local. Well, guess what? All appendicitis is local. It really depends on your environment and what works best in your environment. It's very hard to extrapolate protocols or pathways that work really well in one environment to another. And it's not just, you know, from north to south or from high income to low income countries, but even within our own environments, it's not really a one size fits all. So I'm going to show a lot of slides, but I'm going to go relatively quickly because it's really the concepts rather than the details that are important. And I'll send the PowerPoint to Milind, and he's welcome to share it with all of you afterwards. So what I was going to try to focus on a bit is some of the definitions we're using, because as was just shown, there's still so much controversy. And you wonder, how could it be that the most common acute surgical illness in children in many countries is still so controversial? And, you know, after 150 some years, we should have figured it out. I believe that a lot of that arises from confusion about really what are we talking about? Are we talking about the same thing? And one of the things I've tried to focus on in my research is to clarify that, so that when we speak about generalized peritonitis with an abdominal abscess, we are really speaking about that, because everybody still publishes, I would say 90% of the publications that are coming out or more are about simple and maybe gangrenous and then perforated. But it's not a consistent disease. Perforated appendicitis, as we all know, there's perforation and then there is a bad perforation, and those patients behave very differently. So I think that's been one of the major deficits in our literature. So why is this important to me? And on a personal basis, why have I been so interested? And of course, you know, I'm interested in a lot of things in pediatric surgery, but appendicitis has been, and probably will always be one of the most common ways. And for us here, it's by far the most common way we make a sick child better. So if we still cannot treat that optimally, I think we're deficient. I'm going to try to talk about some of the objectives, the benefits of accurate definitions, and then to target the area of care standardization and demonstrate the value of risk stratification. And maybe the very last line on the last presentation, I do agree that you have to tailor it to specific populations. I'm not sure I agree that it should be different for each patient, or it should be sort of customized for each patient. Even within patient populations, I think you can dissect out certain subpopulations that still should be treated in a standardized way. Why is care standardization important? Because we know that delivering this care in a consistent, repetitive, and reproducible fashion is, you know, to many medical conditions that are available, and care bundles will make a difference. We know that if we do it in a consistent manner, we will get good outcomes, whether it's for heart disease or for appendicitis or for pancreatic cancer or whatever it might be. The other thing about risk stratification is, you know, what is it? Well, we have to assign patient populations to risk groups based on the underlying conditions, the morbidities, the disease presentations. And really, if you think about it, that's the only way to evaluate outcomes. If I'm going to evaluate how I'm doing with somebody, you know, halfway across the world, we have to be talking about the same thing. And if we're not talking about the same thing, our outcomes may be very different, not because our treatment is so important, but because what we're treating is very different. Again, just to point out that, you know, it's been 150 years almost that we've been doing appendectomies, and yet we have all these controversies. And this is, again, a commentary from a paper that was published just a few years back. And You would say like one would think that we should have gotten it by now, and we still don't. So just a quick historical perspective. Really, the Boston people, Boston Children's, I think they should be credited with really making the first efforts to try to standardize care. And this was their protocol, essentially. Now, their protocol was nice because it essentially treated all patients the same, but it was also quite invasive. It put drains in all patients. Patients stayed in the hospital for a long time, essentially 10 days, no matter what kind of appendicitis they have. And it really involved a lot of morbidity. Their outcomes were really pretty good, still among, I would say, some of the best outcomes reported in the literature. But the price for that was a very long hospital stay for patients who had no complications. They were already in the hospital over 10 days, and all patients almost 12 days. So when we think of care standardization, we should not just think of maximizing cure. We should also think of what components may be overtreated. What can we be overtreating? And if we do not continue that overtreatment, we may still be able to preserve outcomes, but minimize morbidity. And for me, every day a child stays in the hospital and does not need to be there, that's a morbidity. It's a morbidity for the child, but it's also a morbidity for the family that may have to get to work or carry on with their productivity. And we're doing some really interesting work now in our division, looking outside the box at things like parental productivity. What does it mean for a child to have to stay in the hospital for a certain period versus go home and continue their care there from a parental productivity standpoint, getting them to get back to work, take care of their other children, etc. Now, our protocol, we've been working really for 30 years, and long before I came here, my colleague, Dr. Laberge and his colleagues were very interested in the whole idea of protocolizing care for appendicitis, and this was essentially a very simple protocol. We've never insisted on a minimum number of days when we treat perforated appendicitis. We discharge patients when they fulfill clinical criteria: resolved ileus, been afebrile for 24 hours, tolerating a diet. And that has been shown over and over to be quite reflective of a patient who has really completed treatment. We actually use oral antibiotics in our service very, very little. The overwhelming majority of patients are discharged without any oral antibiotics. And these were always the highlights of our protocol. We've used inexpensive antibiotics. We do not culture pus because we use an empirical antibiotic regimen. We closed all wounds. We've never put drains, and again, using discharge criteria. And again, from the first publications now dating back 30 years ago, our results again were really quite good. But the difference between our studies and those that came from Boston was that the hospital stay was quite a bit shorter, by almost 30% shorter. And this is when we were thinking of simple and gangrenous and perforated as three groups, and that has changed. I'll show you in a moment. 10 years later, when I was doing my training here, I wanted to see how we're performing. And so we looked at another 10 years of data. And in fact, we were quite consistent once again in terms of what our results were looking like, and really showed that our protocol was doing well. Now, this has been mentioned before, but we know that appendicitis is a continuum. It starts as acute, appendix then becomes gangrenous, and then we'll go on to perforate. And that's obviously the pathophysiology of appendicitis that we all understand. But this area in the middle there, gangrenous appendicitis, what is it? How do you treat it? What are its outcomes? And in many of the large series, in fact, there was a large paper published in the best surgical journal, Annals of Surgery, just last month that I'm reviewing now. And again, they talk about gangrenous appendicitis as if it's sort of like its own entity. So I've been interested in that because that's about 20% of patients. It's not a small group. So the way we went about it is to start looking at what other people have done. And this is the group from Kansas City, which was really the first group to say, we don't believe there's anything called gangrenous appendicitis. Appendicitis is either simple or perforated. And that word complicated appendicitis, we probably should stop using it. It's just a very vague term that doesn't really imply a whole lot. So they said, if you don't see a hole in the appendix, or if there's no fecalus outside the appendix, that appendix is appendicitis, simple appendicitis, and it's not perforated. So we thought this was a little bit aggressive because sometimes you do operate on an appendix and it looks completely necrotic, right? but it's not perforated yet. There's no pus outside the appendix, and there's really no peritonitis, but the appendix is dead, it's necrotic. So we decided to look at this in a prospective manner, and we did a prospective study, not changing what we did. At the time, we were still treating all appendicitis, whether it was gangrenous or perforated, with antibiotics until there was no fever, the criteria I showed. But we just decided to actually do a prospective clean study because, as you know, a lot of the studies on appendicitis are retrospective and the literature is poor, which is, again, sort of really, it really should shame our field that, again, something so common, we're producing relatively poor literature, maybe until the last 5 to 6 years, where the literature really started improving significantly. So we wanted to look at the definition, the bacteriology, the histopathology, the outcomes of gangrenous appendicitis. So we did a study where we followed a cohort of patients prospectively. We wanted to validate a definition, look at the bacteriology, assess the outcomes, etc. And we created a consensus definition of what we believe a gangrenous appendix is. So it is not just subjective, a surgeon looks at it and says this is gangrenous, but had to qualify to satisfy these 4 definitions. The appendix had to be necrotic. There had to be an absence of a fecal lift outside the appendix, no visible hole in the appendix, no gross purulence away from the appendix, and no intraoperative leak. So the appendix didn't perforate while you were operating on it. And we did a 1-year prospective study. We enrolled patients once that diagnosis was satisfied in the operating room. And then again, we treated them according to our standard way and followed them according to our standard way and looked at the standard outcomes of hospital stay, readmissions, etc. So here were our results. 38 patients qualified. That were, again, about 17% of our total. There was a very high histological correlation. If you look at previous studies, the histology of a gangrenous appendix only agreed about maybe 20% with the surgeon's impression. A pathologist calls an appendix gangrenous when there's full thickness necrosis of the appendiceal wall. And in our study, that was way higher. So that definition actually was a good definition. Interestingly, half of the patients had bacteria in the peritoneal cavity. The hospital stay was no different because we hadn't changed. But if you look at readmissions, wound infections, and intra-abdominal infections, those patients actually had the exact same outcomes that simple appendicitis patients have. They were far more similar to those with simple appendicitis and those with perforations. And again, when we looked at cultures didn't seem to make any difference in terms of whether patients stayed longer or later. When we looked at the pathology, whether the pathologist called it gangrenous or not, again, no difference in the outcome, etc. So really, the next step was to think, are we over-treating those patients? Do those patients really still need to have several days of antibiotics until they're completely afebrile and so on? So these were our conclusions from our first study, that these post-op complications are rare. And then we went on to then do another prospective study to really look at what would happen if we were to just give 2 antibiotic dosages, like had been mentioned here, as some centers still do with simple appendicitis, although we don't give any antibiotics afterwards. And we did another prospective study looking at that. And so we had 2 study cohorts. We had the study pre-protocol. We were still treating everybody for a certain period of time until they satisfied these criteria, and the cohort where patients were leaving after they received their 24 hours of antibiotics. And again, when we looked at this, we found absolutely no difference between the groups, except, of course, the patients who were not treated with a longer antibiotic duration had a significantly lower hospital stay. So this actually led our colleagues at Nationwide Children's Hospital in Ohio. They took our work and decided to omit antibiotics altogether and treat it like simple appendicitis. And guess what? They had the same outcomes. So it was really sort of, us kind of capitalizing on work done by our colleagues in Kansas City, and then our colleagues in Ohio capitalizing on the work done by us. And we've all really concluded that we don't believe this is a clinically important entity. An appendix could look gangrenous, could look dead, but if there's no clear perforation, you do not need to treat it like a perforated appendix. And that's what we do now. Our gangrenous appendectomy patients go home the same day, just like our simple appendectomy patients. And we've saved our hospital hundreds of thousands of dollars over the years by not keeping these patients in the hospital. So these are sort of some of the conclusions. Now, moving on to the area of perforated appendicitis, and this was mentioned before. In our practice and in Canada in general, in North America, it's still about a third of children, so pretty significant proportion of children will come in with a perforation. We know that this significantly worsens outcomes as soon as a perforation has developed, and we know that of those with a perforation, those who develop a post-op abscess will even have worse outcomes than the rest of the perforated groups. These things are not controversial. And what is strange, though, is again, you look at series and you'll see abscess rates from 3% to 30%. Well, how can that be? I mean, how can you have tenfold the incidence of an abscess if we're using antibiotic protocols and we're doing the same things? Again, I think a big issue here of definition. And we know that there's still very significant variability in care between centers and even sometimes within the same center if there is not an adopted protocol. So I came here now about 12 years ago. I'd been gone for a long time because I had done my training here. And my initial impression, I round with our residents every Monday morning, whether I'm on call or not. So I see what's happening on our service. And anecdotally, I felt that we're not performing as well as we think we are, because we thought our abscess rate is around 7-8%. And I was seeing far more abscesses post-op than that. So we decided to look at our experience. And this, again, for the young people, it's kind of easy to settle into a practice mode and feel like you're doing well compared to others, etc. But I would really encourage you to at least every few years go back and do some audits. And you might be surprised. Sometimes you may not be performing as well as you think you are. So we went back and looked at this. And in fact, what we found is that we looked at a patient population over 5 years, and we identified an abscess as any fluid collection that was associated with persistent symptoms after the 7th day. Now, this is really important because we have studies that show if you get an ultrasound on a perfed appy patient at day 4 or 5, guess what? You're going to find quote unquote abscess. You're going to find fluid collections. So they had to be symptomatic, either persistent fever, persistent ileus, and have a collection after the 7th day. This was a retrospective study, so the decision was really to do something about the post-op abscess was according to the surgeon. And in a retrospective way, we looked at, we essentially categorized these patients in the categories you see here, whether they had diffuse peritonitis or not from the op reports, et cetera. Of course, again, retrospective studies, so not the cleanest data. And then we looked at many things that may determine abscess. For example, the age, the gender, the type of perforation, et cetera. We did a trend study, and we had a pretty good cohort to look at. And guess what? We were not performing as we thought we were. Our abscess rates had actually climbed to almost 22%, like 3 times what we thought they were. And our incidence of getting patients to go through another procedure, some type of drainage, usually by interventional radiology, sometimes operative drainage, was also going up very significantly. And again, not surprisingly, we found that if you had an abscess, guess what? Your hospital stay just was doubled. So this was not a surprise. Anyway, we looked at the multivariate logistic regression and found some predictors of abscess. So then what we did is we took that data and we decided to once again go into a prospective mode. And one of them was to, for the first time, we started to culture the pus again to make sure that we're not missing resistant organisms or things that we did not know existed. We wanted to make sure we looked at actually were we following the criteria of our own discharge. And we found that many times our fellows were not. They were feeling, okay, patient looks good, let's get them out earlier, let's switch them to oral antibiotics. But in fact, we were not following our same protocol. So we amended our protocol. One of the amendments, for example, was that the staff surgeon now had to approve the discharge, either the staff surgeon on call or the surgeon who actually operated on the patient. And if there was a reason to change the protocol or not respect the protocol, that had to be clarified. Why are we not following our protocol? So we did this again in a prospective study, and it was led by actually our current junior fellow, Dr. Youssef. And we did 2 things. We repolished our and really tightened our protocol. so that we decrease variability as much as possible. And we decided to look at outcomes in a risk-specified way. And this was the grade of perforation that we created, again, by consensus, based on our retrospective data. It was mentioned earlier. Thank you very much. I was really thrilled to see that start to appear in presentations and really be a part of the literature. And we did a 1.5-year study. Our clinical pathway covered all points of care, and we stratified the patient in the operating room, which is one of the weaknesses, is that you have to see, and we do all the cases by laparoscopy. We are looking now at whether we could use artificial intelligence to actually come up with the categorization before you even operate. But even if you classify it in the operating room, you'll see why it's still very useful in a moment. One of the other things we did is, you think everybody knows how to do an appendectomy. And yes, all surgeons, of course, know how to do an appendectomy, but we don't do it the same. We didn't have a standard operation. So we, by agreement with all our surgeons, decided anytime there is a perforated appendicitis, you have to go through all these 8 steps. You have to retrieve a fecalith if it was seen on pre-op imaging. So it's either within the appendix or you look for it. Remove all fecaliths intact, and if it fractures, you have to clean it as much as possible, etc. All the points you see here to, again, to try to decrease the variability of actually what happens in the operating room. For example, many patients will have intra-op or interloop abscesses in the operating room when they have a severe peritonitis. If you don't run the bowel and evacuate these interloop abscesses, you may have an interloop abscess on post-op day 7. That's not a post-op abscess. That's an abscess that was there that was never drained the first time. And again, we standardize all points of post-op care, from who gets TPN to who gets a central line and all of those things. We did the necessary statistical analysis, and we had 122 patients to look at over this 1.5 years, and they were graded as you can see here. So most were either in grade 2, an isolated abscess, or in grade 4, an isolated abscess with generalized peritonitis. And you can see some really interesting things. First of all, if you just look at median operative time, there was actually a trend to an increased operative time with severity of the case. So that was kind of a surrogate that, yes, there was actually more to deal with. Same thing with a free fecalith. Same thing with, the incidence of a severe ileus, etc. So there was really a trend that supported this category risk stratification system. What was fascinating is the overwhelming majority of post-op abscesses, which were 9.8%, which was great because we again dropped our rate again by 50% from 20 or 22 to 9.8 with the standard protocol. And the overwhelming majority, all but one, only occurred in grade 4. So patients with grade 1, grade 3, grade 2, the chances of getting an abscess after surgery were extremely low. We also looked at hospital stay, and you could see a very clear trend towards an increased hospital stay as the grade increase, and this was highly statistically significant. And when we looked at all our resources, the antibiotics, TPN, how many needed more post-op imaging, all of those things were consistently worsened with the higher grades. So why is that important? Because now we can walk out of the operating room and tell the family we have a grade 1, and it's highly unlikely that your child will have a complication. And it's very likely that they will be leaving the hospital in 3-4 days. Likely, we don't make any promises, but we can actually make some pretty good predictions what kind of resources will be needed for that child and how the family can potentially plan. When we have a grade 4, we let them know that there's a significant chance this child may get a post-op abscess and they may need more imaging and so on. So it really sets the expectations both for the families and for the entire surgical team of what to expect. It also helps your threshold of when to suspect complication. If you have a child with a simple, contained early perforation and they still have fever on post-op day 3, you're not going to go and image them and make a big deal out of it. But if you have a patient who has a grade 4 and hasn't opened up at all and still has a severe ileus at post-op day 5, you're going to start imaging them earlier. Anyway, and this is just recapping the data. So we really felt that the risk stratification scheme is a valid predictor of outcomes. not just outcomes, but also resource utilization in children. And far past treating every patient, it allows us to benchmark. So if I'm comparing my outcomes with Milan's outcomes, we can say how many of our patients had a grade 4 perforation. Well, of those, I had 30% get a post-op abscess and you had 20%, so you're doing much better. Let me see what you're doing, how I can replicate that. So it allows us to compare outcomes in a, in an intelligent manner between centers. From our perspective here in North America, it also allows us to, in the US, of course, in a privatized healthcare system, the severity of disease is very important in billing, but even in a national healthcare system like ours in Canada, it's important to be able to translate these into government policies so that they understand that if we're a community hospital, we're going to be treating a different type of appendicitis that in a tertiary hospital, and therefore we need the adequate funding because we need more resources. So it has really a lot of implications. And in these last couple of years, I've been preaching this to my colleagues all around. We should stop saying perforated appendicitis. And you'll see, some of my letters to the editors critiquing papers that still simply talk about perforated appendicitis without telling us who these patients are and what they have. So these are the two papers that I shared. And again, I'll share my PowerPoint with you. This was really 20 years of work with many medical students and residents and fellows participating. So I just want to acknowledge them at the end. So thank you so much. And I will maybe stop my share, and I hope we still have some time for discussion.
Yes, thank you, Sheriff. That was really very educating and very useful, practical. And I think you have actually shown us a direction that we need to classify it correctly, identify it, classify it correctly, and then standardize our protocols. And we have a relatively standardized protocol, but I think we will try and use the stratification which you have mentioned and which Jandile also mentioned in his presentation, and we will look at that. And another important thing, what you mentioned, those all classical steps of operation with perforated appendix with generalized peritonitis. I think we all consultants in our department, we emphasize it time and again. And I think if we miss one or two of those steps, then those patients are the ones which have persistent problems and which need repeat surgery. There are a couple of comments or questions, and I would like your opinion about it. I just go one by one. I think Dr. Ann has asked, is it okay to do an appendectomy in the event of generalized pyoperitoneum? So we will do it. I would like what you would advocate.
The question is it okay to do an appendectomy if you have generalized peritonitis?
Correct, yes.
Yes, absolutely. We do it all the time. The only patients we treat with antibiotics without operating on our service are those we say have a missed perforation. That means a patient with a mass, usually that means an abscess or a phlegmon on ultrasound or sometimes physical exam. And by the way, we neither use CT scan or MRI on our service for imaging patients with appendicitis. It's clinical plus minus ultrasound. And who do not have a bowel obstruction or a severe ileus, and who do not have generalized peritonitic abdomen. And those patients who present late and are completely contained and have an abscess or a mass are no more than about 3% of our total population. So those are the patients we do not operate on. But we operate on patients all the time who have severe generalized fibrinopurulent peritonitis, and we remove their appendix, we clean the abdomen, and we continue them on antibiotics.
Yes, thank you. I think we hardly, we operate. We almost always operate because most of our patients, as Jandile mentioned, they come from far, they present late, and most of them have peritonitis beyond iliac fossa. Many of them are quite sick, present in septic shock, and we do not really follow or practice conservative management and a question of delayed appendicectomy. So that answers first question. what do colleagues say about abdominal drains in frank pus in the abdomen? So my answer was, we don't leave any drains even in generalized peritonitis. I would just like to know what your protocol or your practice is.
We do not leave any drains. The only time I might leave a drain once every couple of years is if I have a very large pelvic abscess.
Yes.
And I know that it has a significant chance of reforming, and I might leave a drain in the pelvis for 3-4 days. We do this maybe once every year or
Yes.
so. It's very rare that we leave any drains in the abdomen at all.
Yes, yes. No, thank you. Any other participants, if you want to ask any question, please just raise your hand, and I'll let you ask question to Prof. Emil. In the meantime, I'll just invite our consultants to make their comments. So first, I will invite Dr. Yashoda Manikchand, our consultant pediatric surgeon, to make any comments. Yashoda, please.
Hi, Prof. I want to thank Zandile. I think he really did a good job in doing his research. And I know there's really a lot of literature on appendicitis from all over the world. So that was a good summary for us with pertinent information for us, specifically in our practice. And I want to agree with him and reiterate that it's really a developing world setting here, and our experience of it. I wish we had more unperforated appendicitis, but we don't. We will have some data soon, hopefully, and we can definitely do audits. So I agree with Prof. Emil that we need to start doing those audits and see how we're doing with management of those. And we can see even how many are not perforated, which I think is a very small number. And it's for the reasons that Zandile said. They are from far, they are not picked up in time. So there may be gaps in the district hospitals, diagnosing them and referring them. So there's many delays before we get our patients. Yeah, I don't think I have anything more. And I want to thank Prof. Emil, because we should start using a more specific classification so we can get the most out of our audits and our research in our department and to compare. He gave us a good, his literature is very good to compare to and to guide us as to what we should be looking for. Thank you
so much. So maybe I'll just make a comment. So one of the limitations, if you will, of our classification is it's based on laparoscopy, which really shows you and removes a lot of variability in what the surgeon is seeing. When you see fibronupilian peritonitis in 4 quadrants, everybody's going to call that generalized peritonitis. There's no controversy. The problem is how you classify them. And this was a question on the chat of midline versus right lower quadrant or a gridiron incision. And this is actually something I'm working on with surgeons at the Albert Royer Hospital in Senegal also, who have an interest also very much in standardizing their care and stratifying their outcomes. We need to create an appropriate classification for how patients present in sub-Saharan Africa. And I'd be really interested if somebody wants to work on that, because I think it is hard to really accurately put patients into this category if you're operating through a small right lower quadrant incision. If you are making a midline incision, then I think you can obviously see what's going on and really make the classification much easier. But perhaps the classification may not be so much based on what you're seeing, but maybe based on how the patient is presenting. And I think that's the interesting thing to look at, is it could potentially be a hybrid of presentation variables and surgical finding variables. And I'd be really interested to work with anybody who is interested in looking at that.
Yes.
Thank you. Yes, I think that is a very pertinent point you brought up, because we were looking at the classification, and we do make that decision based on the clinical presentation of the child. And and we're trying to do more laparoscopic, but we're doing more open by far. So I think, yeah, I think we will be very keen to work with you on that.
Yes, thank you, Yashoda. I think we will discuss soon and we will start implementing the classification. And I think we will certainly like to participate in any further research where Canada and South Africa and maybe even some African countries, we can collaborate together and have a combined research protocol. I see there was a question from Dr. Kudzai. Do you routinely irrigate or suction only? And Prof. Emil has answered that he does both. And we also do both. We also irrigate in addition to doing suction. I see there is a hand raised by Dr. Gamal. So Dr. Gamal, please unmute yourself and ask your question.
Thank you very much for this the nice presentation from Dr. Sharif and the other presenter for the comprehensive presentation, and there's a lot of knowledge that he presented. My question, if there is any protocol for management of cases of acute appendicitis, either non-complicated or complicated with in the era of suspected cases of COVID-19, I suspected or proved cases, there is a protocol for that?
Yeah,
Amal, where do you work?
I'm Dr. Gamal Said, is a professor of pediatric surgery at Al-Azhar University, Cairo, Egypt.
Oh, thank you. Welcome. Okay. So, Dr. Emil, you can answer the question.
أهلا بك Dr. Gamal. Forza Said. It's a great question. Yes, we have had to change our protocol early on because we didn't know what to expect, right? I mean, when we were doing this a year ago, we really did not know what to expect in terms of the burden of children. So our protocol changed in the sense that all patients were started on antibiotics, and we awaited the COVID testing. Now, the COVID testing at that time was not coming back in an hour or two. We did not have rapid COVID testing, so it would often take 12 hours or more. And our protocol was to treat all patients with antibiotics if they tested positive for COVID, unless or after 24 hours of antibiotic treatments, they showed some evidence of instability. And what is the rationale for that? The rationale for that is that there are many centers, and as was actually mentioned in the great presentation earlier, non-operative treatment is becoming more common. We certainly know that at least 70% of patients will succeed. Now, we don't do that on our service because we believe a 30% failure rate is high over a course of a year. But nevertheless, it is within the standard of care right now. We can no longer say that, no, it's not standard of care. I think non-operative treatment is within the standard care. So we did change our protocol to put all patients on antibiotics, and if they do test positive for COVID, to continue them on antibiotics and only operate on the ones who do not respond. That was our protocol. Now, having said that, as time went on, we realized that the number of patients who had COVID actually was quite small. So we did not actually have to implement that much. And essentially just delayed the surgery by about 12 to 18 hours. But we know that if you put patients on antibiotics, that the pathophysiology is arrested. So this is how we adapted to the COVID era.
Thank you, Dr. Sharif. Also for the choice for laparoscope or not, there is also included the protocol?
Yeah, this is a fascinating question. There was all this concern that laparoscopic appendectomy may actually expose the team more because of the insufflation and all that. Yeah, I mean, that's a great question. I have to say, I am not as familiar with that literature myself, but from the little I saw and the fact that most of our patients anyway, the chances were very low, we did not change, we did not go to open appendectomy. Now, our sister hospital here to some degree did. So, I think that was kind of a localized preference. I have to tell you one other thing about COVID that's fascinating is this PIMS syndrome, pediatric inflammatory multisystem syndrome. We've had several patients present classic appendicitis. And in fact, we find a normal appendix. And just a few weeks ago, I operated on a patient. The only thing unusual was that she had a temperature of 39.6, and yet the other presentation was like simple appendicitis. She did not have diffuse peritonitis. I went in, the appendix looked inflamed for sure, it was not even marginal. I removed the appendix, and the child came back later, 2 days later, with high fevers, close to septic shock, and she had COVID and PIMS, and the pathology of the appendix came back normal. So we continue to learn about this whole issue of COVID and how it's still interacting with the diagnosis of appendicitis.
Thank you very much, Dr. Sharif. Thank you very much.
Pleasure.
Ramadan Kareem.
Yes, thank you. I'll just invite Dr. Selo Machaya, our other consultant, to make any comments. Selo?
Thanks, Prof. Thanks, Zandile. Good presentation. Thanks, Prof. Sharif, for your time and for giving us your insight on this topic. But for some clarity as well, and some questions that I saw in the chat regarding the approach, we have almost like a standardized approach where someone comes in relatively quite toxic looking, and with general peritonitis, we'd err on the side of doing more of a lower midline incision and extending it appropriately so it can get adequate exposure of the whole peritoneum and give good irrigation in all quadrants of the abdomen, instead of starting off with the lines, or we hardly ever do gridiron and extending it across. So it's certain situations where you initially assume that the appendix is just inflamed with no perforation, and when you open with your lens, you find that there's quite a lot of pus. Then you just extend it across the midline to get adequate clearance. But I think the important thing is that irrigate as much as you can, as much as some literature says that you can just suction and it's enough. I was taught from a long time ago that the solution to pollution is lots of solutions. So I flush them thoroughly until the water going in is as clear coming out. It makes me sleep better at night. There are lots of things as well, controversies around antibiotics, but I'm not going to deal with that. We still do a lot of open laparotomies because our patients generally come in perforated, quite a large proportion of them. And the time is also a factor as to when they present, because we don't have a dedicated facility of just performing laparoscopy at midnight. Obviously, I also try to encourage, especially the juniors, to not try to do appendicitis at midnight or 1 o'clock in the morning. Just resuscitate the child and wait for more a suitable hour to function, which is first thing in the morning. But because of constraints that we have in our low to middle income society, we find that if you don't catch an opportunity at midnight, 1 o'clock to do the procedure, you will delay the child getting done, might actually get done the following day in the afternoon or even in the evening. So that's where our laparoscopy becomes limited. We tend to do a lot of laparoscopy during working hours because we're all there, we all can partake. It's just that we have shared services with adult surgeons, so we can't focus on that as much. The other thing that how we generally base on certain patients anyway, whether you're going to do open versus laparoscopy. We got this from our colleagues at Red Cross Hospital in Cape Town, where they looked at the patient's CRP, and there were, as you know, as much as it's not specific for appendicitis, raised white cells and CRP has increased sensitivity. So they were basing their knowledge saying that CRP being elevated, particularly above 70, would be more of an increased risk of having a perforated appendix. So they may err on the side of doing more of an open appendectomy, or have someone more experienced deal with the appendix laparoscopically versus letting a junior do it, where, as you know, a more inflamed appendix versus a perforated one, it's a lot more easier to manage. And the last comment I think I'll make is what Vered Luck, our colleague in Joburg, is making about planned laparotomies. We generally base our doctrine on doing relook laparotomy as on how the patient presented. Generally, they're coming in with septic shock, which quite a few of our kids do come in that state. We automatically anticipate for us to have problems, particularly prolonged ileus. So we automatically choose to put a central line so that we can initiate TPN quickly. But at the same time, using the discretion of the surgeon, we consider doing a more standardized relook laparotomy within 48 hours. We highly follow up with ultrasounds, especially for these ones with generalized peritonitis who are not settling within 2 to 3 days. We opt just to take them back to theater and just wash them out again. And we find that that actually helps them settle quite a bit and quite quickly. Otherwise, that's my 5 cents. And yeah, I'm sure Prof. Sharif, Prof. Chitnis will definitely help us collaborate with you in the appendicitis study, because as you were saying, one of our registrars is actually starting his MA dissertation. So it would be a good collaboration, I think. And yeah, we're looking forward to it. Thanks.
Well, thank you. I really look forward to that as well. And I think your comments are superb, and that's really what I wanted to hear, because I have a whole lot to learn about the challenges that you all have to deal with.
انا بقول لحضرتك حق قلت لي اطلع من هنا وحق سالت من هنا.
والله ما خدتش بالي.
I think you brought back what we started with, is that all appendicitis is local, and you have to do what is really works well in your surroundings. I have to tell you my experience though, when I was in Southern California for many, many, many years before I came here, yeah, we were not, as in a challenging situation as you are, but actually we saw bad disease. 50% of our patients were perforated. A lot of indigent patients who had no medical insurance, a lot of immigrant patients who were worried to come to the hospital because of illegal status. I mean, very difficult, and many patients were sick for days. So not unlike at least some of the patients you're seeing, maybe still not quite as severe, but not unlike. And I have to say, what I found is that if I'm going to struggle with an operation laparoscopically, I'm going to struggle even more with it open. And so the chances now that I convert from laparoscopy to open I don't remember, honestly, one that I did that for in about 10 years, because you have to just go slow, methodically, what you see, from what you see to what you don't see. And in some instances, I've just cleaned up the belly as much as I could and left the appendix, don't insist on removing it. And in some instances, that's actually the patients do very well, and you can decide later on to come do it or not. So I just want to not leave people with the impression that, a bad appendicitis means that you have to do it open. Certainly in many, many environments, that could be absolutely the best scenario. And that's why, again, it's important in yoga, but I find that it still gives me the ability to visualize things much better than in an open procedure, and to really go about a lot more meticulous dissection.
Thank you very much, Sharif. I think final concluding remarks, and what has been very useful for this presentation is our understanding has improved. We have a plan to start classifying our appendicitis, especially intra-op. And one of our registrars, Dr. Jula, who presented, is very likely to take appendicitis as his thesis. And I'm sure we will have a collaboration between you, us, and maybe some other hospitals in South Africa and in the rest of Africa about this in the future. So just some final concluding words from you, Sharif, and then we will.
Well, my only concluding remark, Melinda, is thank you again. I learned a ton. I really think this is about learning together, and it's really been just an amazing thing. I would love to collaborate. You know where to find me, and we go from there.
Yes. No, thank you very much. And please just email me your presentation. And what I will do is I will then share the recording and Zondile's presentation and your presentation for those who couldn't attend. So thank you. We will see you in the future and we will keep communicating.
Very good.
Our next 2 Tuesdays will not be open for the people outside our staff. Coming Tuesday is a public holiday and the following Tuesday is only for our department. The meeting after that, I think it's on the 11th of May, will be on postnatal investigation and management of hydronephrosis due to pelviureteric junction obstruction. And Dr. Sujit Chowdhury, who is a senior consultant pediatric surgeon and a urologist in New Delhi, India, will be our invited guest. So thank you, everybody. Have a good day, and we will see you in 2 weeks' time. Thank you, Sharif, once again.
Good evening.
Bye-bye.
Thank you so much.
Bye-bye.
Bye-bye.